Hello, and thanks for listening to the MiCare Champion Cast. In today's healthcare landscape, delivering high-quality care isn't just about clinical outcomes. It's about connection and collaboration between patients and their caregivers. In this episode, we'll learn more about patient and family-centered care, which challenges healthcare teams to rethink traditional roles, elevate lived experiences, and design systems that listen as much as they treat. At the MHA, we continue to support our members in these efforts through our Person and Family Engagement Advisory Council, often referred to as PFAC. This work group represents hospitals across the state who are focused on developing resources that make person and family engagement, otherwise called PFE, more accessible. Joining me virtually, I have two guests who share a name. The first is Michelle Brady, a registered nurse of 36 years who is currently the Director of Patient Experience and Relations for MyMichigan Health, where she supports the success of the system's Person and Family Advisory Council. In this role, Michelle is dedicated to ensuring the patient and family are at the center of goal setting and system decision-making. Our second guest is Michelle Mitchell, a nationally recognized patient advocate and breast cancer survivor whose journey reflects an unwavering commitment to transforming healthcare into a system centered on patients and families. Michelle M. began volunteering at Michigan Medicine in 2011, where she co-chaired the Department of Pathology's Patient and Family Advisory Council for over 9 years. She's partnered directly with clinicians and hospital leaders across the care continuum to help create a culture where patients and families are valued as essential collaborators rather than passive recipients of care. Michelle and Michelle, thank you both so much for being here today.
Yes, thank you for having us.
Thank you. It's a pleasure.
You're joining me ahead of Patient Experience Week, which takes place April 27th through May 1st. I provided a little bit of background on both of your roles, but can you help us understand a little bit more about what inspired you to enter this field of work? And I think in today's healthcare landscape, it's also important to mention what has inspired you to stay in this field of work. Michelle B., let's have you kick things off.
Awesome. Thank you. What led me here? I was called to this work. I can't imagine ever wanting anything else or thinking about being anything else but a nurse. I had some excellent role models as a little girl growing up, and then personal experiences through my life that led me to healthcare, and it was just a natural fit. And I've loved my job for 36 years plus. So what kept me here, what keeps me inspired, is the amazing privilege I have to impact lives, whether it was as a young nurse at the bedside or working in the ER, or today in leadership roles and working to inspire new nurses and new healthcare providers. It feels like just a very humbling privilege to walk alongside people on some of the most beautiful and the most heartbreaking days of their life.
Absolutely. That's a great answer. Michelle M., what about you?
Well, that was a hard act to follow, but when I retired from Blue Cross Blue Shield of Michigan in 2009, and I worked there for 25 years in healthcare leadership, I chose to devote my time entirely to patient advocacy, pro bono. And that decision became deeply personal when I was diagnosed with breast cancer. Suddenly, I was on the other side of the system that I'd spent my career in, and no one was really explaining what was going on. I felt lost and overwhelmed, and that experience lit a fire in me that has never gone out. Since then, the work has grown far beyond what I imagined. Globally, I serve on a number of committees. I'm on the American Society for Clinical Pathologists Patient Champion Steering Committee, which is a global organization. And I'm also on the Digital Pathology Association's Patient Engagement Committee. And then locally, I've always volunteered at the American Cancer Society. I contribute to the Michigan Cancer Consortium's Clinical Trials Project. But what truly keeps me going is personal. I've walked alongside family members and loved ones through diagnoses and real moments of fear, and helping one patient at a time get the best possible care. That's what really drives me.
That's another great answer. And I think, to your point, you both have such vast experience, both professionally and personally, that informs the work that you do. I think a good place to start this conversation is helping our listeners understand the philosophy and impact of patient-centered care. I mentioned it in the intro, but just a reminder throughout the episode, we're going to be referring to it as probably PFE. But Michelle B., can you tell us what the impact of this work is on patient outcomes and overall hospital operations?
Yes, MyMichigan Health, our care delivery model is a patient-centered, person-centered care delivery model called relationship-based care. And that care delivery model is interprofessional, very interdisciplinary, and it focuses on 4 key relationships: the relationship with self, the relationship with your colleagues, then the relationship with patient and family, and the relationship with the community, and how that community relationship is very bidirectional in its impact. That being said, for MyMichigan, it completely aligns, the PFE concept completely aligns with our purpose statement of creating healthy communities together, and understanding that the patient and family is at the center of everything we do, knowing that without the patient and family input, hearing their voice from all of the listening posts that their feedback comes to us from, has a direct impact on our outcomes, right? How can we improve our patient outcomes if we don't know what our patients want, if we don't really understand the cultures and the needs of our communities? We can assume what they might want, but until we hear from them, that's where our true impact comes. And by engaging with them, we know it also builds their trust and loyalty to
Absolutely.
us as an organization. Does that answer your question, Lucy?
Yeah, it does. And I think it touches on a few really important points. And you mentioned trust. And as hospitals and healthcare systems get bigger, I think people feel a little more disconnected to their providers. So to your point, collaborating and creating a space where they feel like they're a part of their care journey is more important than ever. We know that a lot of these models look different across different hospitals and health systems. Michelle, can you speak to your perspective on that question and how the philosophy of this works?
Thank you for the opportunity. Yes. At the heart of PFE, in my opinion, is about shifting from doing things to patients to working with them, similar to what Michelle was talking about. Now, that sounds simple, but it's a profound cultural shift in how we think about about patients' role in their own care. You know, imagine how that feels for someone who has never worked in medicine, someone who doesn't know what to ask, who is afraid to push back, who leaves the appointment maybe more confused than they arrived. And that is the gap that PFE is designed to close. And this is evidence-based. It's compelling. A peer-reviewed study in PubMed entitled Impact of Patient Engagement on Healthcare Outcomes is really worth looking at. And the findings are striking. First of all, there's better patient outcomes. And what they said in the study is that active engagement improves chronic disease management, and patients who participate in their care stay healthier longer. Secondly, they said there's higher patient satisfaction, just as Michelle had said. And when patients help shape decisions, they feel heard, respected, and in control. Thirdly, they said there's adherence to treatment plans. So engaged patients follow through more consistently, reducing dangerous gaps in medication and follow-ups. And fourth, this is what really gets leadership's attention, lower costs. The study pointed out that there's fewer readmissions and preventable complications that mean real financial savings. So this is just not just the right thing to do, it's the smart thing to do.
Yeah.
And for me, PFE is also about restoring humanity to medicine, which is what Michelle had said. Patients are not conditions, they are people. And the best care happens when providers see the whole person, not just the diagnosis, as Michelle had pointed out. When patients are genuine partners in their care, everybody wins. There's no downside to getting this right.
In our organization and personally, I believe relationships are at the heart of everything. It
Right.
all comes down to the relationship. The relationships we build both while patients and families are with us in our clinics, our practices, our hospitals, our outpatient settings, those relationships can be made in a moment. That caring, that connection happens in a moment. We can't take that for granted. And it's in those moments that they're with us, and then moments they're outside our doors when we have the opportunity to engage them the way a PFE does. Those relationships create those buffers for us, right? So, like Michelle said, when she was lost and she didn't understand what was happening, she didn't know. With a strong relationship with your provider and your health system, you have some of those buffers for when we do miss the mark, when there is some trust we need to recover, which again can lead to that cost savings, right? Those are those soft dollars that you can't really put a number on, and we have to respect the fact that they're there.
Yeah. We didn't have this in the initial, I'm going off script a bit, but I can you give an example, Michelle B., of what it looks like, how your PFAC operates? So if I were a patient, what would it look like, the engagement with the PFAC?
So at our organization, patients, families have multiple different ways that they're invited to participate in and I'd love to call it an advocacy council, right? In our council. And they can access that and learn more about it through their patient portal, through our external website, through the information that's given to them when they're in the hospital, when they're at the office. We have multiple different ways we've worked with marketing to help socialize that, and through our social media platforms. And when they express interest, we try to roll out the red carpet for them to welcome them in. And we are, I would say, at the infancy of this process at MyMichigan. I've been part of the MHA's PFE Advisory Council, and pre-COVID, post-COVID, you saw things. We tried to get things off the ground, and then that pandemic happened, right? And post-pandemic was almost the perfect time for this.
Right.
Patients were more highly alert and aware of things happening in healthcare around our organizations, and really wanted to be heard. And so we've used that to redesign, restructure, reboot our organization's councils.
Yeah, absolutely. Michelle, and how would you say the landscape of patient-centered care has evolved from your perspective?
I think this is a perfect segue from Michelle to me. Well, when I started my role at Michigan Medicine, it was way back in 2011. So it was a long time ago. Patient advocacy at that time in hospitals, I would say, was a very much nice to have. Patients were involved, were invited to come to these councils, but often in a token way. We were in the room, but we weren't shaping the agenda. I remember sitting in early PFAC meetings where the agenda was handed to us, already written. We were asked to react to it, and that really wasn't a partnership. But what's changed over the years is dramatic, and the evidence, and it's based on evidence. And I'm going to point out another study that I ran across. It was a major 2023 Cochrane systematic review, one of the most rigorous analysis ever done on this topic. And they screened over 15,000 studies. And it confirmed that true partnership between patients and providers generally improves care design, service culture, and the physical environment where it's delivered. But the review also pointed out that there are some issues, some critical warnings every hospital leader needs to hear. Simply having patients in the room is not enough. The research identified 3 barriers that consistently silenced patient voices, even when patients were technically included. First of all, there is a power imbalance. So when Providers control who gets recruited, who gets invited, who sets the agenda. And the representative voices there are representative voices that are left out. So what happens is the loudest, most comfortable, most available patients fill the seats, and your full community goes unheard. I thought that was very interesting. Secondly, what they noted was medical jargon. I sat in meetings where acronym after acronym flew across the table and watched patient advocates quietly shut down. You know, if you don't understand what's being discussed, you can't contribute. And these studies pointed that out. A practical rule I always like to share is if you wouldn't say it to a patient in the exam room, don't say it at a PFAC meeting. And thirdly, patients not feeling like part of the solution. So when advocates are stuck reacting to topics, they disengage. And I've seen experienced advocates simply stop coming because they feel like window dressing, not partners. So the Cochrane Review conclusion of this study is direct. Successful partnerships require health providers to continually reflect on and address the power imbalance. This is a call to action.
Yeah. Well, that touches on one of my next questions was going to be what works and what doesn't. And I think you touched on that a bit. Michelle B., is there anything you would add to some of the comments that Michelle made?
A couple of things reacting to the Cochrane study, and I don't know, Michelle, if you're aware of the book written by Stephen Traziak and Anthony Mazzarelli. This was back in 2017, I believe, and they wrote a book called Compassionomics. They're both practicing physicians in Ohio, and they partnered and ended up with fantastic research that showed that the data correlation between patients who rated their physician high and who felt listened to and respected by their physician on their CGCAP surveys, those patients had better health outcomes. They had, in their research, they looked at A1Cs in their diabetic patients, and they looked at readmissions in CHF and pneumonia, and noted that those patients who had that feeling of partnership, respect, courtesy, all of those things really did have better outcomes. And so it's a fantastic read for a patient experience nerd like myself. So
Me too. And I do want to say that there are things that I believe we can do to make them, to make these things better, including, but I think the single most ingredient here is leadership commitment. You know, it's not just a policy statement. Michelle has embedded it in her organization clearly, but it's not just a policy, it's active, visible champions, and really at every level. And then beyond that, I think that there are a few other things that make a real difference, and that is clarity of role. Patient advocates need to know what they're being asked to do, and they need meaningful work, not just attendance, as I mentioned.
For sure.
And there needs to be a culture of mutual respect where lived experience and professional experience are treated as equally valid, and that titles are checked at the door. And then I do believe in the ongoing feedback loop. PFACs need to regularly revisit their goals, measure progress, and celebrate wins. And examine, are the goals still the right ones? Are advocates still finding meaningful work? You know, that kind of honest reflection is what keeps a council from going stale. And it's what keeps advocates engaged and coming back. And just as important, patients need to see their feedback actually land somewhere. Close that loop every time. Tell people what you heard and what you changed, because the moment patients feel their input is being collected and filed away, you've lost them.
Absolutely.
And I just want to mention one other thing. I found out that some institutions are even using what I'll call a patient secret shopper. There are people who move through the care experience with completely fresh eyes and report back. And I love that idea. Real engagement means really being willing to hold the mirror up honestly and then act on what you see.
For us, as I mentioned, being relatively in this infancy stage, some of our councils are more mature than others throughout our organization. We use the MHA roadmap to get us started. When we were first coming together with stakeholders across the organization, it was coming together as a patient experience, as an extension of patient experience, right? As another space to hear our customers and hear our patients and learn from them. And we've evolved. I think at the beginning, we perhaps focused on too many details and not enough on the spirit of what we were trying to accomplish. Therefore, we lost some interest in getting people to co-chair and do things like that because, we were really focused on the application and on the structure and process. One thing about me, structure and process is not my zone of genius, right? I often laugh that some people think in Excel and I think in a word cloud. And so it was really important that we had that balance on our planning team. Those people who love to stick to the project management piece of it and march it along. I wouldn't get anything done without those people. And myself and some others who really tried to focus on the human side of this. We're not just trying to check a box for Leapfrog or for other quality initiatives and things like that to say, do you have patients and families on your boards, on your, are you including them? We wanted this to really fit the spirit of what we were trying to accomplish. When we noticed we had some areas where we were lacking engagement, we weren't getting applications, again, leaning into our marketing team to reboost some posts on social media, things like that, partnering alongside our fund development team, our volunteers, to get the right people at the table to, what do we call them, the connectors on the advisory council, right? Learning about that and the power that they have. And we've had 2 really cool wins recently. And you talk about that closing the loop and bringing to the council, what are your ideas? Not bringing the agenda to them, right? Having them bring us their agenda. And it's there was an issue with rugs. Like they were just really concerned about the amount of rugs we had in one of our organizations and the trip hazard and how they slipped and they fell and the risk it put the health system at and different things, and I come into this thinking big picture workflows and how are we going to expand our market share and are you using your patient portal and what more digital connections do you want? And the council came and we talked for a meeting and a half about rugs. And I was like, okay, right?
Who would have thought? Yeah.
Well, come to find out, you go back to the facilities team, whatever, and all of a sudden, these rugs in this area were gone, right? And you were able to go back. They had sent pictures and different things, go back to this council and say, well, we heard you and those rugs are gone and we're going to do this type of, inlay type flooring instead and we'll move towards that. And thank you for bringing that concern forward. And much like a shared governance structure with unit practice councils and having our staff closest to the patients be involved in the workflow, the delight on the faces of these folks in this council about these rugs, then the next month they come back with other ideas and with more and more, and you build their trust on just these small things. And while we're so focused on AI and our greatest and latest technology and the new shiny bauble, right? Our patients want to be safe and they want to be heard and respected and seen as people and not just the widget, not just the next the next case, right? So I could
Yeah.
go on and on, so don't worry, I won't.
That was a really powerful example.
If I might, I was thinking as you were talking about something similar. I don't know if you've probably been to the Ann Arbor Hospital. It's sort of it's very confusing. There's basement 1, basement 2, and this sort of thing. So one of the things that we did on one of the earlier councils that I was on was bring forward as patients, is there anything we can do to, for wayfinding, to find your way around? And so so from our idea and bringing this forward, they launched the ambassador program, which volunteers staffed, and now they wear a little jacket and they help. That's what they do. But I also wanted to talk about, it doesn't have to always be big bang. For hospitals that are resource constrained, you don't need a large volunteer program to get started. So I want to encourage your listeners, look at your post-visit surveys, opt-in checkboxes on your patient portals, focus groups. They're all low barrier options. And if community volunteers simply aren't available, you can still capture the patient voice through data you're collecting already. And I know you do this, Michelle. Patient relations reports, complaint logs, discharge survey trends, and patterns in your patient portal messages. The data tells a story, and mining it intentionally is a form of patient engagement, even without a single volunteer in the room. Provider referrals are incredibly effective. Over 95% of Michigan Medicine's patient advocates come through staff referrals. But I'd encourage every hospital, of course, to use that pipeline. But you need to be honest about who you're pulling from. If you're only referring patients who gave you a 5-star rating, you're hearing from one half of the room. And the patient who had a difficult experience, who flagged something through patient relation, that voice is just as important, and maybe more so. Real improvement requires the full picture, not just the comfortable one. Another thought I had is perhaps a peer mentor program. This is pairing an experienced patient advocate with someone with a newly diagnosed patient. It improves satisfaction, reduces anxiety, and, builds a pipeline of future advocates. And for academic medical centers like Michigan Medicine, there's a powerful opportunity, which I have actually been a part of, and that is partnering medical students and nursing students directly with patients as part of their training. When you expose future clinicians to the patient experience early, before habits and assumptions are formed, you're not just improving care today, but shaping people who will deliver care for the next 30 years. So those are just some of the ideas that were popping into my head as you were talking.
So much power in narrative medicine, right? What does Brene Brown say?
Yes.
Stories are data with a soul.
Yes.
And
yes.
That's very true. And I think another thing that the advisory councils do so great at keeping to the forefront. Had a mentor in my work with relationship-based care, Mary Kolarudis, and one of her most impactful writings that she did, she has a quote, and it said, "We must never remember that although it's routine for us, it is never routine for the patient and family." And how true, and to keep that thought, we can get so entrenched in our work, right? And we think about, how are we giving people their pathology results? Is it showing up in a portal? What's our process, right? Are we holding people through this and truly not letting, while we have these benefits of this beautiful technology, right, and the gift of all of these advancements, that we cannot lose sight of the human connection.
Yeah.
And I truly believe through advocacy councils, advisory councils, this is our lifeline to continue that humanizing the experience, humanizing the care across the continuum. We have to keep the patient at the table, the family at the table.
Yeah, and I think to each of your points, the foundation of a lot of this work is based in the culture of the hospital or the health system. So I am curious how it feels like such a big task to shift the culture. And Michelle B., to your point earlier, people, I think it's very easy in the speed at which healthcare moves to be kind of checklist operated when it comes to engaging employees and also knowing that culture kind of starts from the top. How do you shift people's approach to care to lean into this model? And how do you get the attention of your leaders?
I feel really fortunate at MyMichigan Health that, it's the organization that raised me, truly, and we've always been so deeply embedded in our community. We have several critical access hospitals. We're rural in many of our locations, and we take care of our friends and neighbors and our family members. Our staff are our patients. Their family members are our patients and families. So culturally, it's kind of who we've always been. Now maintaining that culture through the evolution of healthcare. All organizations, I think, have ebb and flows in that. We believe in a transformational leadership style where we have that shared vision. The staff know what our vision is. They know what our goals are. We share them very openly. We're very deeply rooted in transparency. I think that helps the staff trust leadership, and it helps the C-suite have further trust in the executive level, and all the way through. I think our strong shared governance, strong unit practice councils, and having these great connections with leadership has helped that as well. And at the end of the day, we have to walk the talk. And I'm really proud of our patient relations. And one of the cultures is you used to hear, well, they're a vice president of this, or they're the president of that, or they're a board member. And in our locations, it's okay, we're going to treat everybody like that, like they're our family. And staff won't believe us. The community won't engage with this unless they see the behavior and they feel it in our interactions.
I think, too, you need to ask where else could a patient voice change outcomes or impact the work that you do every day. It's a question I think that should be asked. I know at Michigan Medicine in Ann Arbor, I'm part of a number of unit-based committees. And so these are, and I'm the only patient on there, so I'm involved in the infusion area, outpatient area. And we're working on some really exciting things, but it's, it puts the patient close to the actual work being done.
That's great.
So, and I think that's a really important thing. And I agree that it's, it has to be a philosophical shift. And also, I think it's really important to make it part of your orientation process, your review process. Patient centeredness really needs to be a part of that in order for you to get that culture shift. So it's not just a checkbox,
Right, absolutely. I think you've both touched on some really, really valuable tools to kick off a patient-centered care model, and whether it's coming up with a committee or an advisory council, using the data that exists in some of those patient experience tools, feedback gathering, focus groups, our roadmap, which I know we're in the process of updating at the MHA. What other tools that we haven't touched on would you want to call out?
I think something that was helpful for us is reaching across to some of our neighboring health systems, looking at our colleagues we looked within Michigan Medicine, but we also looked at some of the other neighboring hospitals and how are you doing this and what's working well for you, and being open to that feedback and open to those ideas and really getting curious about it. Also, I think spending time in reflection. We spent about a year in one structure that we had laid out, and we were just weren't achieving the engagement we had hoped, and things just we were starting to kind of lose our the wind was coming out of our sails with it, right? And being open and flexible to come back to the table, right? Plan, do, study, act. We studied it, and like, okay, we've got to make some adjustments, and feeling supported by leadership to do that, and trusted by leadership to, okay, we're going to do this. We might have to build the plane a little bit while we're flying, right? But we're going to do this, and it doesn't have to be perfect to be really, really good. At the end of the day, it might be about the rugs, and
exactly.
And until we're on to something else, then we worried about the rugs, right? So.
Yeah. We might have to rename this episode.
Yeah.
Check the rugs. It might be about the rugs.
The rug completes the room. No, I was thinking as you were talking, Michelle, too, and it can, I have been sort of, I'm a frequent flyer. I have a lot of health issues. So, and I've witnessed that sometimes the face to the patient is that person who checks you in. That person who checks you out, the phlebotomist that you meet.
Absolutely.
These encounters have lasting effects. Like you said, you take that with you.
Yes.
You have to remember that the patient is coming in on probably one of their worst days. They're not feeling well, or they're worried about something.
Scared.
So having just a warmth, someone who's kind, who can, approach you in a positive way, goes such a long way. And so sometimes they're just simple fixes.
Oh, so simple.
Right?
We make things too difficult sometimes. I was working with a team who were looking at their outpatient patient experience scores, and one department was doing very, very well, and a very similar department in another building was struggling. So I said, okay, what's different, right? What's different here? And it was a relatively new leader. And she said to me, oh, I know what that is. Sue works over there. She's really nice. And I'm like, we can't have nice be the differentiating thing, right? We need to mature past like that. That shouldn't be the exception, right? That somebody is nice. And I think through some work we do in our organization, where we spend some dedicated time taking care of the staff and some reigniting retreats, it's really remembering too that we all have our thing, right?
Yeah.
That we bring, and our story that impacts how we give care and how we receive it. And while we can't know everybody's story, we have to have the awareness that it's there, and come ready to meet them where they're at. And by taking good care of ourselves, we're responsible for the person that comes to work every day. Nobody else is. And to take care of that person so that they can be of good service to their colleagues and the patients.
Absolutely. And we didn't touch on it, but I'm just going to speak from personal experience, having been in sort of a caretaker role to a close family member recently who's in the hospital. That makes a huge difference for the family too.
Yes.
Feeling seen and understood when you're in a place of fear and not understanding, and you might have a family member who can't, be present to take in all the information. So you have to juggle your own fear with trying to understand everything that's happening. So to have, a care team that sees and hears you is major. And in my experience, you have people who know what they're doing. Just you can tell it's in their soul, and then some people who are just it's well-meaning, but they don't necessarily realize that they're kind of running through the checklist. And you're like, wait, are you looking at my situation? Are you seeing me as a caretaker here? So it makes a huge difference. But I cut you off, Michelle.
No,
what were you going to say?
I was just going to absolutely 100% agree with you. I've taken care of both my parents, my husband, my stepdaughter who passed away from cancer. And a lot of times I felt like I was, I had a third eye in the middle of my head when I entered the room, like I had physicians and care teams say, well, are you a doctor? No, I am just really concerned about my loved one. And I feel, as the caregiver, I don't know if you felt this way, Lucy, I feel the full weight and responsibility for whom I'm bringing into you. You know, I'm turning over the wheels to you, and I'm trusting you, and this is my loved one. So I'm not trying to be a know-it-all. I'm trying to be a part of the team. Please include me in that. And look to me as someone as part of the team. I've actually had to say that a couple times. Listen, I am part of the solution. I want the best care for my loved one. That is why I'm here.
Yeah.
You know, and it is it's a heavy responsibility to carry as caregiver.
Yes.
And I think that's really well understood, I think, a lot of times.
Mm.
Yeah, that could be a whole other podcast in itself.
Yeah,
and Michelle, you called yourself a frequent flyer.
Yes.
I've heard that referred to as a sophisticated user.
Oh, there you go.
You look much more like a sophisticated user than a frequent flyer. So
there you go.
Well, I appreciate you both so much, and this has been such a valuable conversation. So much of it is resonating for me on a personal level. But I want to close out just hearing any wisdom you have or that you would pass along to others who are in the early phases of adopting a patient and family engagement model. So Michelle B., let's have you kick things off as we've been doing, and we'll go from there.
Begin where you're at. Don't wait for it to be perfect, and let it be small, right? And don't quit. Just keep moving forward and ask for help, right?
I love that.
Well, I'm going to take a little different angle, and my final thought is for anyone out there, you know, a call to action for anyone considering becoming a patient advocate. And so I have some advice for whoever that might be. And I would say start with your own story. Your experience has value. Begin by advocating for yourself. And as you grow, so does your confidence and your voice. And that becomes the foundation to advocate for others. I would suggest that you find your footing, identify an organization whose work aligns with your passions, connect, volunteer, and contribute, but embrace the paradox of advocacy and expect pushback, but do it anyway. Always be assertive but professional. And if I might, if you would indulge me for a moment, I ran across something called the Paradoxical Commandments by Kent M. Keith. And there's several that I feel pertain to advocacy, which I love and I have posted on my computer that I read often. And things to remember. The good you do today will be forgotten tomorrow, but do good anyway. Honesty and frankness make you vulnerable, but be honest and frank anyway. The biggest ideas can be shot down by the smallest minds, but think big anyway. Give the world the best you have, and you might just get kicked in the teeth, but give the world the best you have anyway. And that is the spirit of advocacy. And I just want to end with this. I have no formal power, but I do have a voice, and I will keep using it until every patient can see and every clinician remembers the life behind the diagnosis. But together, we can shape the future of patient-centered care for all. And I thank you so much for this opportunity to share my thoughts along with great leaders like Michelle. And I thank the MHA for bringing this very important topic to your listeners. Thank you.
Yeah,
Absolutely.
Thank you so much. It's a beautiful note to end on. I want to again thank you both for being here today and lending your insight and such valuable experience to the conversation. I'm really excited for this one and to share it with our listeners. Is there anywhere that you would send our listeners to learn more about you two or your organizations? Anything else you want to add before we say goodbye?
I don't think so, but thank you for the offer. Of course, I'm out there on LinkedIn and
Oh, me too. I can share all that connection. I have my own YouTube station now.
oh my
I love
goodness.
that.
With all my advocacy work. So I'll share that with you after. And also, I'd like to share the link to those 2 studies that I mentioned.
Yes.
And
yep,
perhaps,
we will have.
Michelle,
Sorry, go ahead.
you could share the book title. I didn't, because that sounds fascinating.
Mm-hmm.
Yeah, we will include links to everything that was mentioned in the episode in the description of the episode. But again, I just want to thank you both so much, and I hope you enjoy the rest of your day.
Thank you, Lucy.
Thank you. Thank you so
Michelle.
much. Thank you too, Michelle. Have a great day.
With that, I'd like to thank our listeners for tuning in and encourage you to check out the description of the episode to learn more about our guests or access resources mentioned throughout the conversation. For more information on our MHA Person and Family Engagement Advisory Council, head to MHA.org.